of ST segment elevation in MI. So we can see all are changes of myocardial infarction of ST segment. So you can appreciate most of the septate are convexity upwards. You can see convexity upwards or horizontal, and everywhere the ST segment is not isoelectric. It is above the normal isoelectric line. What is the normal isoelectric line? The normal line of the heart. So if we see one ECG here, this is the normal isoelectric line, the long line that has shown. This is the line of the long normal isoelectric line. See, if the ST segment has to move up, it will have to move from here and then come down. So this point is known as J point, and there should be a J point elevation. Beginning of the ST segment is called the J point, and there should be J point elevation to get to the ST segment. ST segment is a flat isoelectric. Elevation of depression of ST segment by 1 millimeter or more is significant. J junction point is the point between QRS and the ST segment. So there should be ST segment elevation in case of myocardial infarction. And if there is a ST segment is depression, it is called ischemia. Now you can see this is normal ST segment, this is elevated ST segment, and this is depressed ST segment. Everywhere you can see the junction point has been increased, and it is convexity towards the upwards. So in acute coronary syndrome, nowadays we use the term acute coronary syndrome. And acute coronary syndrome can be ST segment elevated myocardial infarction or non-ST segment elevation, ST segment myocardial infarction or unstable angina. There will not be any ST segment changes, but patient will have symptoms of it. So here it is very well described what is the J point elevation we are talking. J point where the QRS complex and ST segment meet. You can see the QRS of complex is meeting the S and T segment from beginning of the S to beginning of the T waves and the end of the T waves, and you can jolly well see beginning of the T wave. You can jolly well see it is isoelectric here, and if it has to elevate, there are clinical pictures, the coved, convex and convex pattern. So frowny pattern we say, and if it is not coved, J point notching, it is not myocardial infarction, but maybe early repolarization or pericarditis. Pericarditis may cause ST elevation, but there it will be concavity upwards. This is also very important. Convexed. So you can see evolution of acute MI. We will show first there will be small increase in the T wave amplitude and J point is starting to elevate. Then the J point has elevated. Then after some time, it will come down and T wave will be inverted. There will be inversion of the T wave. So according to time, we can say how much time has elapsed from the ECG itself, and also we can corroborate it from the history of the patient. Initially, there will be T wave changes, we can say hyperacute T wave. So A is pre-infarct normal, tall T waves first few minutes of infarct, tall T wave and ST elevation, injury has occurred, and elevated injury, inverted T wave, ischemia, and Q wave tissue death. Significant Q wave, when it is seen, there it indicates tissue death post infarct. Q wave is a permanent marking. Now we all know that from the ascending aorta, the left coronary artery, the left main coronary artery appears, and it divides after some time to left anterior descending artery and left circumflex artery. So this is left anterior descending and this is left circumflex. Circumflex and anterior descending. Okay. So left main coronary artery has two branches, LAD and left circumflex, and there is right coronary artery is there. So these are the three main arteries which predominantly are main supply of the heart. If we see the right coronary supplies the AV junction. So in case of right coronary artery infarction, arrhythmias is more. This is very important. And but if in case of left main coronary artery, because it covers most of the heart, the fatality is more. And if you see the left anterior descending, it supplies the mainly the anterior wall and the anteroseptal wall, and left circumflex the lateral and anterolateral wall, and right coronary supplies the right side and the inferior and posterior wall basically. So if they are affected, changes will appear on that part of the heart. Now after ST segment, we need to see some problems for the T wave, because T wave changes are also typical in myocardial injury or acute coronary syndrome. T wave normal, T wave is asymmetrical, first half having a gradual slope, then the second should be at least 1/8, but less than 2/3 of the amplitude of the R wave. T wave amplitude rarely exceeds 10 millimeter. Abnormal T waves are symmetrical, tall, peaked, biphasic, or inverted. T wave follows the direction of the QRS deflection. Now, you see different types of T wave. They are all normal. Normally, T waves are inverted in AVR, because in AVR everything is inverted, and it can be inverted in V1 normally. If T wave abnormality is there in consecutive two leads of the same wall, then it is called significant. What does that mean? Consecutive two leads of the same wall. So I told you anteroseptal, anterolateral. So if we see anatomic groups, septal V1 and V2, anterior V3 and V4, lateral V5, V6, and 1 and F8. There is nothing to memorize. If we look at the heart and look at the positions of the ECG leads, I told you in the previous class also, that if you look at the heart from outside, it will look like these are the leads which look at the heart from that side. B1 to B2 and B5, B6, they look at the heart from the lateral side, and anterior side. And if you see there are changes in the 2, 3 and AVF, it will be showing effect on the inferior wall. So what I was telling, that in consecutive two leads there are T wave changes, then it is considered abnormal. Suppose there is only negative T wave in lead 2, but in lead 3 and AVF, T waves are normal. So it is not significant. There should be at least two leads of the same wall having the problem. Suppose there is problem in the V1 only, but there is no problem in the other leads, then it is not significant. But if there is problem in the V1 as well as V2 as well as V3, V4, we will call anteroseptal wall changes. Got my point? So tell me, if there are problems with the 1 AVL and V5, V6, which wall it is affected? Anyone?
Lateral wall.
Yes. Lateral wall will be affected if V5, V6 and 1 AVL. So I will show you one ECG that tell me which wall is affected. Can you appreciate ST segment elevation?
Yes, sir. V1 এ আছে, V2 তে আছে, V3 তে আছে।
Anteroseptal wall.
Anteroseptal wall. Very good. So V1, V2, V3 and V4. Got it? And there is one ventricular ectopic also there. So this is one ECG complex which looks differently. This ECG looks different. So it is ventricular ectopic beats. So it is not similar with the other complexes. So one beat has come from some ectopic foci. That's why it is called ventricular ectopic beats. It is different from the others. And in this ECG, if we want to read this ECG, rate is about 1, 2, 3, between 3 and 4. So rate is around 85. Rhythm is sinus. Every P wave is followed by QRS complex. P wave morphology, 2 wave, দুঘর ঠিক আছে। PR interval 4 ঘর normal. ST segment it is not wide, and axis 1 up, AVF up, it is normal axis. And ST segment there is changes. ST segment elevation quite from it is J point is also elevated, and there is coving pattern is there, and there is appearance of Q wave also. You can appreciate the first negative deflection of Q wave. It is there is no R wave. You can see V1 to V4, there is Q wave, first negative deflection, it is deep downward, but it should have been a R wave. So this ECG shows anteroseptal wall, ST segment elevation, myocardial infarction of some duration. Why we are saying that it is of some duration? Because Q wave has already appeared and T wave changes are seen. T wave inversion has also started appearing. If we see carefully, there is also ST segment elevation in V5, V6 also. So if you look at it carefully, there is J point elevation in V5, V6 as well as some J point segment elevation in lead 1 and AVL also. So there is extensive anterolateral. So there is extensive anterolateral wall involvement. So total anterior, in fact, we can say. So evolution of acute myocardial infarction, above they have said it is 3 hours. So 3 hours time has elapsed. That's why these changes are occurring. What is this? ST segment elevation in, it is shown in the picture. V5, V6, 1 and AVL. Which wall is it there? It is written.
inferior wall.
না ইনফিরিয়র ওয়ালে ডিপ্রেশন আছে গো, এভিএফ এ ডিপ্রেশন আছে, আমি বলছি ওটা এলিভেশন আছে হচ্ছে B5, B6 and 1 AVF. It is lateral wall MI, but we can see there is depression in AVF. What Onamitra is trying to say, that there is depression in AVF. It is called reciprocal changes. একটা বাড়িতে যদি আগুন লাগে তার পাশের বাড়ি থেকে জল ঢালতে আসে, সেটা হচ্ছে আজকাল যদি কেউ আসে না, কিন্তু তার জেনারেলি পাশের বাড়ি থেকে আসে, তখন পাশের বাড়িতে জলের সংকট হবে। সেই জন্য আমরা বলি যে ওয়ালে ইনফেকশন হবে তার অপোজিট ওয়ালে ইস্চিমিয়া হবে, কেননা সেখানকার রক্ত এখানের দিকে চলে এসছে, তে ওকে সাপ্লাই দিতে যাচ্ছে, ওখানে আগুন লেগেছে, চলে যায় নেবে। So it is one of the surest sign of MI, because one wall will have elevation and the just opposite wall will have depression. What is this?
লিড 3 এভিএফ এখানে এসটি এলিভেশন আছে।
Very good. So 2, 3 AVF, there is ST segment elevation. Which wall is this?
The inferior wall.
Very good. So it is, can you appreciate reciprocal changes?
AVL.
Yes, 1 ABL. So if there is infarct in the inferior wall, the opposite wall is anterior wall, there will be ischemia. So you can see lead 1 ST segment depression, you can see AVL ST segment depression, you can see V2 also, you can see very good ST segment depression can be seen. And there is some elevation also in the lateral wall. If we see that in V5, V6, there are some elevation. Sometimes the big right coronary artery, apart from supplying the inferior wall, also supplies the lateral part of the heart. So there can be inferior lateral MI also. So this is purely inferior wall MI, but small changes can be seen in the V5 and V6 also. And there is reciprocal changes. So this is a surest sign, I told you. This is inferior wall acute myocardial infarction, ST segment elevation myocardial infarction. We call ST segment elevation myocardial infarction or non-ST segment elevation, where there is ST segment elevation has not occurred, but ST segment elevation not occurred, but other changes can be seen, like T wave inversion is seen. So acute coronary syndrome, a constellation of symptoms related to obstruction of the coronary arteries, with chest pain being the most common symptom, in addition to nausea, vomiting, diaphoresis. Chest pain concerned for ACS is often radiating to the left arm or angle of the jaw, pressure-like character, and associated with nausea and sweating. Chest pain is often categorized into typical and atypical angina. So, chest pain due to cardiac cause, we see cardiac chest pain or non-cardiac chest pain. Cardiac chest pain has some specific characters. It is stabbing or heaviness, people say, and it is towards the left side of the heart and it radiates to the jaw or left arm, and it increases on exertion and associated with nausea, vomiting, diaphoresis, that means sweating. So these are characteristic of if you have one patient with chest pain with risk factors of coronary artery disease, a male 40 years of age, diabetic, hypertensive. Now you know the risk factors of coronary artery disease. There are some modifiable risk factors. There are some non-modifiable risk factors. Modifiable risk factors are body weight, diabetes, hypertension, lipids, stress. They can be modifiable, and non-modifiable like age, sex, genetics, and like that. So if the patient has risk factors and have typical chest pain, you should look for ACS because acute myocardial infarction, 10% people die within 1 hour. So many people die within 1 hour. If you do not diagnose it well and he dies, will be in difficult position. You have given the patient some antacid gas theory. We have in India, we call it everything occurs due to gas, and gas. But you should remember that gas will not kill, but myocardial infarction will kill. So you need to be cautious and admit the patient. Acute coronary syndrome, nowadays we call ST elevation myocardial infarction, non-ST elevation myocardial infarction, and unstable angina. The ST segment elevation engine is ST elevation and elevated cardiac enzymes. Non-ST segment elevation is ST depression, T wave inversion, and elevated cardiac enzyme. Unstable angina, non-specific ECG changes, and normal cardiac enzymes. What are the cardiac enzymes? You have learned thoroughly in the biochemistry as well as pathology classes, and we know trop I is the first to rise, but it remains positive up to 2 weeks. So in reinfarction, trop I is not useful. If the patient is admitted and he was admitted for acute myocardial infarction and there is another chest pain after 7 days, trop I will remain elevated. So if there is fresh MI, we cannot say. Trop I rises early but stays for about 10 to 14 days. CKMB will be the test of choice because it rises within 4 to 6 hours and stays for only 48 to 72 hours. So we have to repeat the CKMB. Creatinine kinase MB is specific for heart. Creatinine kinase can be BB or MM. So CKMB. ECG is the first point of entry into ACS algorithm, abnormal or normal, neither 100% sensitive nor 100% specific, because if it is normal, you have to repeat it. Single ECG for MI, sensitivity 60%, specificity 90%, but repeated ECG, the sensitivity increases. So if you are worried, repeat the ECG every hour. Represent single point in time needs to be real in context. Normal ECG does not exclude ACS. 1 to 6% proven to have MI, 4% unstable angina. So if the ECG is normal but the patient still have symptoms, you can go for echo, or you can repeat the ECG. You can go for cardiac enzymes. You should admit the patient, give the first 3 drugs. What are the first 3 drugs? Aspirin, clopidogrel, and
Aspirin, atorvastatin, clopidogrel.
2 antiplatelet and statin you should give. And analgesia if it is needed, and you have to identify if it is ST elevation MI, you need to try for either thrombolysis with streptokinase, nowadays we use RTPA, or you need to do primary angioplasty. Primary means without intervention we are doing angioplasty, but if it is done within 6 hours, the results are very good. After that, results are not that. Now, initial 12 lead ECG should be done. Gold or 2 ECG time, 10 minutes, read by experienced doctor. So, goal of DOT to ECG time, because if the patient has come to the emergency and you are doing ECG after 1 hour, you may be sued. So, time is money. Time is, we say, muscle here. We sometimes say time is money, but here time is muscle. So goal to door to ECG times. The ECG should have been done within 10 minutes, and if there is facility of angiography, it needs to be done within 90 minutes of admission. If ECG not diagnosed, highly suspicion, serial ECG is initially 15 to 30 minutes. ECG adjuncts, you can look for the V7, V9 or RV4 if you are suspecting right ventricular or posterior wall infarction. Continuous 12-lead ECG monitoring, reasonable alternative to send ECGs can be seen. If we monitor the patient on cardiac monitor, we can also appreciate in experienced eyes, we can appreciate are there changes are occurring or not. So these we have discussed what can occur, J point elevation with convexity upwards. In concavity upwards is there, it may be due to early repolarization or pericarditis. Evolution we have discussed. We will have tall T wave, then we will have ST segment elevation, then we will have Q wave and T wave infarction. We have discussed about different valves. One AVL B5 B6 is lateral valve, 2 3 AVF is inferior valve. So this is the crux. And B1 to B2 is septal valve, B3 B4 is anterior valve, B5 B6 1 AVL is lateral valve. Is non-ST elevation MI, ST depressions occur or T wave inversions occur without Q waves in two contiguous leads with prominent R wave or RS ratio more than 1. Isolated T wave inversions can correlate with increased risk of MI. Many represent Wellens syndrome. Wellens syndrome, what is it? What is Wellens syndrome? It is there is critical LAD obstruction and the mortality is very high. Unstable angina may present with non-specific or transient ST segment depression or elevation. Now this we have discussed, and electrolyte changes we will continue on the next class. Thank you.